Okay, so we're going to go ahead and get started. Welcome everyone who's joined us. My name is Lauren. I'm the project coordinator here at Northwestern for the National Collaborative for Education to Address Social Determinants of Health. I have a few housekeeping items before we get started. Please mute your lines. We will have time at the end for questions and answers. You can either type your question into the chat box or you can raise your hand to access the microphone. If you have any other applications or windows open that you don't need, please close those now. And a recording of this will be available on our website. I want to introduce our speakers briefly. So from the University of Illinois, we have Dr. Ray Curry, Dr. Mimona Hasnain, and Dr. Nimi Rajagopal. And then from Rush University, we have Angela Blood and Dr. Susan Glick. And then kicking us off today is Dr. Daniel Evans, and Elizabeth Ryan is also here for questions. So Dr. Evans is the director for the Education-Centered Medical Home Clerkship here at Northwestern. And with that, I'm going to go ahead and pass it off to Dr. Evans.
Thank you so much, Lauren, and thank you everyone for joining us this morning. I'm sure everybody's busy in the middle of their work week here on a Wednesday, so we appreciate your attention. And as you listen to what we and our collaborators at Rush and UIC have to say, please, if you have questions, please feel free to enter those on the group chat. We'd love to, we're going to make sure we save enough time at the end to address all your questions. So this whole project started in 2010 as part of a curriculum renewal here at Northwestern, and I'm going to share sort of our journey. This is the title of our talk. You could also call the title of our talk, You Can't Master Chronic Care Management Without Managing Some Patients Chronically. That's kind of sort of the spin-off here, and we'll go through this. I organized the talk using Dr. Kern's approach to curriculum development for people who are medical educators and designing any curricular innovations at your institution. I highly recommend this. I'm not going to go through all this in detail, but this is just sort of how we organize the talk, and we'll go through these one by one. So Dr. Kern's first step in curriculum renewal is problem identification and needs assessment. So back in 2010, what was the healthcare problem that we were trying to address when we first proposed creating the ECMH? I think the number one thing is addressing a chronic care crisis in America. As of right now, we've got 150 Americans with chronic illness, half of them with multiple chronic conditions. The knowledge that 5% of the superutilizers account for 50% of all healthcare costs. The knowledge that 80% of all Medicare costs every year are spent on chronic care management. And in spite of this incredibly skewed distribution of medical resources towards chronic care, certainly our care delivery system has yet to completely catch up with this, and medical education-wise, I would argue we're a decade behind. We have not evolved our medical education structure to address chronic care, which is what all of our graduates are going to be focusing on in their careers. Visually, what does this look like? This is a graph from Medicare data. Basically, the numbers to remember here would be 50% equals 3. So 50% of the entire population only drives 3% of all healthcare costs, and the other number is 5 equals 50. So the top 5% utilizers are driving 50% of the costs. When we, certainly back in my day when I went through medical school on my clerkships, I had no sort of sense of this kind of skewed distribution. It kind of was equal time for every specialty without any sort of recognition that there's certain medical conditions and certain patients that are huge drivers towards illness, disability, mortality, and cost. And the clerkship structure really does not address this at all. So what did we set out to do? So if the problem identification is we have a crisis of chronic care, it a little bit drives me crazy to say that, in my opinion, the best medical writer of our generation is a surgeon, but I will give Atul Gawanda props. These are two of his kind of recent pieces, Cowboys and Pit Crews and Heroism of Incremental Care. If people have not read these, I highly recommend them. But I think these two articles really distill a lot of our chronic care crisis and how we need to change the system, both care delivery as well as education. Here at Northwestern, kind of one of our mantras is we want every student in our ECMH program to feel like they were part of a pit crew, and we want every graduate to feel that they experienced the heroism of incremental care, and I'll come back to that. So step 2 is needs assessment for our learners. What are sort of the things our learners need? And I'm going to go through this very quick because it's pretty simple. Back in 2010, if we had a crisis of chronic care, we talked to our graduates, and basically our graduates told us they never saw a single patient back for a follow-up visit. And we talked to our faculty, and our faculty only worked for students on average for 1 or 2 weeks at the most. So if we're going to try to manage conditions that evolve over years and decades like diabetes, going to be very hard to teach students up to mastery if they never see a diabetic patient for a follow-up visit. So step number 3, we have a chronic care crisis and if we have a lack of follow-up or continuity, what is our goal and objective for the curriculum reform? And I'm going to go through a patient story here. So this is Catherine, one of my favorite graduating students. This is a picture of her 4th encounter with one of our favorite patients, Beatrice. And I can use her name because she gave me permission. So you could probably guess from this photo some of the things that Beatrice is complaining about during this visit. She has a headache. She has chronic dizziness. She is frustrated about her medical situation. She is frustrated about her medicines, which are laid out next to you. And I'm going to go through sort of how Catherine's journey with Beatrice, kind of how it builds on learning about the social determinants of health. So certainly in medical school, I think our students are pretty well given slides like this on social determinants of health. They kind of understand the concepts of how economics and community safety and physical environment impact health, but I think it doesn't hit home until they take care of a patient over time and see the direct impacts. So for Beatrice, understanding social determinants of health took time for Catherine. The first visit for Catherine with Beatrice, she's a first-year student. She hadn't covered diabetes. She had just barely learned about hypertension. And really that first visit for Catherine, she was just learning how to take a history. Everything else was over her head. The second visit, she really dove in more on some of the chronic medical conditions. She knew more about diabetes at that point. She knew more about colorectal cancer, which her patient had a history of. So now she's experimenting above and beyond just the history of present illness. The third visit, she took a crack at medicine reconciliation, and that was the visit before this photo. She took out Beatrice's shopping bag full of pills. She tried to reconcile all the different medications, many of which she had duplicates of, and she probably took about 50 minutes with this patient doing a full medicine reconciliation. On the 4th visit, this is the photo, all of her efforts the previous visit were all for naught. And in spite of organizing the pills and putting them in a pill dispenser and teaching the patient up on each specific medication, the patient still had no idea how to properly take her medicine. On the 5th visit, Catherine focused on teach-back, tried to really dive into the health literacy issues with this patient and try to slowly kind of improve the understanding on these medicines. On the 6th visit, when Catherine was finishing her 3rd year, Beatrice asked us for $20 to get home, and it was that clinic visit where we really realized just how much her finances and her home situation were impacting a lot of her adherence and a lot of her medication issues. And it was the 7th visit as a 4th year that Catherine started to understand why Beatrice was in the emergency room on a regular basis at a hospital near her house. Basically, we started to see a pattern emerge that it was always Friday or Saturday night that Beatrice would end up in the emergency room about 10 p.m. And it became clear that she was worried about her grandson getting caught up in street violence. So if we want our students to really understand the social determinants of health and how it kind of evolves and impacts patient care, I would argue strongly they will never get it if they don't see patients back for follow-up visits. So step 4, what are some strategies we can do to try to maximize this important concept of social determinants of health? I think continuity is really the number one strategy that we came up with, and I'm going to go through some details of how we implemented this. We wanted our students in existing clinics kind of adopting a panel of patients that needed outreach and really working with them over time. And we wanted to change the culture from let's just see who's on the schedule for today, which is sort of the traditional individual preceptor model, towards here's your list of high-risk patients. You're going to be with me in this clinic for 4 years. What can we do as a team to improve the health of these patients over time? And we focused during the curriculum renewal about, are we going to build a new house or are we going to renovate the house we have? Are we going to tear everything up on the clerkship structure and build longitudinal integrated clerkships and revamp everything, or were we going to sort of take the existing structure we had and tweak it? And I think different people have different approaches, and I don't know if this is necessarily correct or incorrect, but if we were really going to change the delivery model and focus on chronic care, we felt like tearing up the clerkship structure was going to be too much, and we decided to renovate the house we had. So we layered a longitudinal experience onto the existing clerkships, and we'll go through kind of what that looks like. So implementation, so if I've got 600 students at Northwestern and I'm going to need to get them all in team-based longitudinal experiences, how in the world are we going to do this? I think this is where we discovered the magic number 16. We realized there was no way we were going to be able to come up with 600 continuity clinics. So we tried to come up with a multiple of 4. What did we think was going to be the maximum number of clinics that we could potentially ever generate? And we thought 40 clinics maybe with using existing partners. So that was going to require cramming 16 students into each clinic. And what the heck would that look like? It would look like this. Getting a panel of patients that comes consistently, getting one consistent preceptor, and then having a consistent peer group of 16 students that are equally divided amongst the 4 classes. And at first this seemed preposterous, and I think people thought this was never going to work. And I think I'm not going to go through this slide. This is just more for reference what an average day in the clinic looks like. How can you cram 16 students into a clinic? This is how we do it. But I'd say the magic was cramming that many students at one time in a clinic created a peer group that has had tremendous benefit for the students' education and allowed us to successfully, right now this year we're up to half the class at Feinberg School of Medicine. We've got 20 ECMH clinics. We've got 300 students involved in the program. And this is a map of where they are in Chicago. We have maybe about 40% of those students are clustered downtown, and more than 50% of the students are out in community-based clinics. Evaluation and feedback. So what have the students told us about this experience? If we have a crisis of chronic care and we want our students to see chronic illness, I think we've proven that they see this. So this was a sort of a word cloud representation of what the students in my clinic saw over 25 consecutive visits. And if we wanted them to learn about diabetes and hypertension and high cholesterol, they saw that. We asked our students kind of their opinion of the program. So this was a survey of graduating students back in 2014, and I'm going to go through this very quickly. This is available in Academic Medicine from 2014 if you want more detail. But the students basically said they saw more follow-up visits, they had more meaningful relationships with patients, they rated the clinics better in efficiency, equity, patient-centeredness, they had a higher satisfaction with their primary care experience, they had less exposure to some of the negative aspects of the hidden curriculum, and the punchline would be likelihood to recommend. We asked if for incoming M1 students, would they recommend students joining an ECMH, or would they recommend doing the traditional individual preceptor model, and overwhelmingly our students recommended the ECMH model was superior. And this was the students in an ECMH, but even amongst the students that never had the experience, they had the similar recommendation. A side effect of this whole reorganization, I'd say this was not our focus when we set out, but one of the things I'm most proud of is that we used existing clinics and community partners, and as a result of this, as of this year, we've got more than 25% of all Northwestern students are embedded in basically underserved communities at free clinics and federally qualified health centers, which is something that we had not had a lot of student exposure to traditionally. And curriculum maintenance and improvement. So if you're going to build a curriculum and you want to keep it getting better every year, another nice thing about our program is that we've built in an annual QI project for every ECMH. We asked our students each year to identify one thing they want to improve in their clinic, and use authentic patient data and use the EHR at their site and try to improve that. So we sort of have a model embedded with each student and with each clinic that, you know, maybe things aren't perfect this year, and maybe we need to tweak the schedule, and maybe we need to tweak patient flow, and maybe we need to address chronic care in a new way. But each year the students know they're going to identify a problem and work towards a solution at their clinic, which has been I think a very valuable part of the program as well. I'm going to leave this for reference. Won't go through the details, but basically, could this model improve patient care? I would argue it might. We had students at a Chicago clinic called Community Health Clinic, which is equally staffed by Northwestern students and other Chicago medical schools. And I'd argue at baseline, the patients were having similar quality, regardless of what students were taking care of them, but simply changing the model and having the students there more regularly and focused on QI projects, they made a significant impact on HIV screening, hepatitis screening, and cancer screening. So this is just our summary slide, and then I'm going to hand it off to my collaborators at UIC. The problem in my mind is a crisis of chronic care. Our major impediment was a lack of follow-up visits. Our goal was to increase continuity with patients, preceptors, and peers. Our strategy was to build teams and use existing clinics. Our implementation was to bundle students in packages of 16 and use that as a team-based intervention to focus on chronic care management. Our evaluation was students and faculty have rated this very highly and have kept coming back every year. We strive to keep getting better every year with our ECMH QI Day each year, and dissemination, that's why we're here today. So I'm going to hand it off to my colleagues, Dr. Curry and Dr. Rajapul at UIC.
Thank you, Dan. Let's do a sound check here. Does this come through okay?
Yep.
Good. So we are part of the dissemination project that Dan and his colleagues are involved in. I was delighted to get a call from Northwestern here a couple of years ago now about the project, including dissemination. And we felt like we were an ideal dissemination site for the ECMH because we're a very different institution. We're a state institution located in a neighborhood where we have a lot of high need patients. We happen to be, here, let me, can I advance this?
You should be able to, but I can if it's not working on your end for some reason.
Why don't you do it, Lauren?
Sure.
We happen to have a very large, in fact, one of the oldest FQHCs in the country here on campus and wholly owned by the university, called Mile Square Health Center. The genesis of the name, in fact, comes from the fact that the neighborhood in which its original location was planted back some 30 years ago was a square mile that had some of the worst health statistics in the country. We have targeted Mile Square as our initial pilot site and developed a program that is piloted this fall. In fact, the very first clinical session will be in about 2 hours. I'll give the microphone in a minute to Mamuna, who can tell you a little bit about the group that we've recruited and the sense of how the initial pilot will play out. But I'll try and do it from 30,000 feet here. It was not the perfect time for us to do this pilot. At Northwestern, and I was at Northwestern at the time when Dan started the pilot, we anticipated the new curriculum by 1 or maybe 2 years. Was it 1 year, Dan?
About a year and a half, yeah.
Yeah, so we had a little bit of experience with the pilot, and it didn't overlap with other curriculum development activities and implementation activities quite so much. Here we are in the midst of very intense curriculum development activity across all 3 campuses of the College of Medicine. So it has been difficult to insert this additional factor into some of the planning when admittedly it needs to start as a pilot. The other ramification of that is that the existing curriculum that is currently now in the 2nd through 4th years, the first year curriculum, new curriculum is in progress this fall, doesn't allow the scheduling of ECMH sessions very easily. One thing Dan didn't focus on much was logistics, but just very, very briefly, if you're going to have multiple sites in the community, just as with any such program, even with individual preceptors, you typically end up using several half-days per week and rotating the preceptors that you're using on a given half-day, even perhaps using some twice a week. And there aren't very many windows in the 2nd year, and clerkship directors in the 3rd and 4th year are not yet used to having people leave their clerkship in this manner. So it wasn't very easy to start across all 4 years for a large group of students. The other advantage we have is what's called the Patient-Centered Medicine Scholars Program. This is a program that Mamuna, who is with us here, started a number of years ago that is a special curricular program for a segment of the class interested in community-based chronic care, primary care activities. They have, to date, they have focused mostly on community-based projects outside of routine clinical care such as this, but this pilot fits very, very nicely into the overall construct of the program. So what we've done is take PCM scholars students as our initial piloteers and create a single site as a pilot based at this Mile Square facility that you see here. The clinic is in the first 2 floors of that building. Next slide, please. When we were talking about implementing this in such a very different setting, one of the things that was essential to work through was the question of what the core of the ECMH model is. The Northwestern program evolved within that setting, within that context, and has a number of features that are specific to the context. We got together and tried to figure out what it is that the essence, the special sauce, as Dan likes to call it, that had to be part of what we did as a pilot. And you see here a photo, it was in one of the earlier slides too, of our special sauce meeting, I guess you could call it. That's me in the back with the very same tie I'm wearing today. This is a high fidelity presentation. To my right is Mamouna Hasnain, and seated at the far right with the dark sweater is Nimi Rajagopal, and then Dan in his blue shirt at the head of the table. So the essential elements that we felt had to be in the sauce. A primary care focused clinic. You can imagine chronic care in a subspecialty setting. What becomes lost in that kind of setting, though, is the breadth of experience that a student would need if you're going to devote such a large chunk of their time in medical education to the setting. So primary care focus is one of the essential elements. Continuity, and Dan has already emphasized this, but the real secret to the success of this is continuity in all these dimensions, with the preceptor, with a peer group, with a set of patients, a core set of patients, and with the staff. And we thought it was essential that the clinic have an EHR to manage patient care because the students are so dispersed at times, because it's such a large team effort. That bullet says continuity over at least 4 years. It probably more properly should say ideally over 4 years. There have been some people who have experienced it for 2 years. There have been some people coming in a little bit later, and so forth. I think the more the better. When the students at Northwestern have been involved for 4 years, it really does become the centerpiece of their medical school experience. The peer teaching opportunities, as Dan has referenced already, there needs to be sufficient volume. This is a potential problem that we're very watchful for in the FQHC environment where no-show rates are high. And then Dan has spoken already to the pit crew philosophy and the value-added, well, we haven't spoken to value-added medical education, but these things taken together are essential to providing a meaningful patient care experience for the students rather than what I'm afraid is sometimes the glorified shadowing that happens when you have more intermittent contact with a single student, a single preceptor. Sharing the care with the students and being able to have students truly feel responsible for the patient's care. Next slide. Oh.
Sorry.
Sorry. There are some optional things that are part of the Northwestern construct or could be part of a construct like this that might not be absolutely essential, but certainly helpful. One is the potential for the ECMH to be an interprofessional education experience. We have that potential at UIC with 7 health sciences colleges here on the same campus in Chicago. We have not yet, well, actually in the site, in the Miles Course site, there are pharmacy students that we hope to bring in very, very soon as we get our feet on the ground, but potentially a much more fertile ground for IPE. Team sessions, linking the students' activity in the clinic with their hospital activity or with transfers to different care settings. And then, as Dan talked about the QI project, this is certainly a big plus for the students. Is it essential to be part of the secret sauce? Perhaps not. And then next. And
then Ray, for the sake to make sure we leave enough time for questions at the end, should you want to focus more on your current clinic starting this week or go into the Peoria or save that for Q&A session?
Yeah, let me just mention briefly that we do have 3 campuses and that we're probably going to be disseminating beyond Chicago very soon. The quick and dirty the thing about the evolution in Peoria was that taking on first-year students, they realized that they needed to double their preceptors, and knowing about the ECMH model made it possible for them to say, perhaps we don't have to have twice as many preceptors if we have first-year students on campus for the first time. Let's just double up. And they have the beginnings of an ECMH right there that will grow year by year. Just perhaps a word from Mamuna about the recruitment of students and the deployment of students at Mile Square.
Sure. So good morning or good night, everybody, wherever you are on the globe. So a couple words about the Patient-Centered Medicine Scholars Program. We started this program in fall 2007, also as a HRSA-funded longitudinal continuity of care curriculum, which spans the undergraduate medical training, and it includes a service learning program for second-year medical students. And our service learning program actually predated this, and prior to that, we started off on the whole area of cultural competency. So our original dream was also to have a continuity of care experience for our students across the 4 years. And due to logistical reasons, what we ended up doing was having a longitudinal experience for our first-year students. They're paired up with primary care clinicians, and they do work in their clinics in outpatient settings. And the second-year program is organized into 5 concentrations for service learning, working with our community partners, which include domestic violence, geriatrics, HIV/AIDS, homelessness, and immigrant and refugee health. And regarding the Team QI project, our 4th-year component allows the students to work on these team projects, also morphed now into an interprofessional experience where we have students from nursing, pharmacy, social work, public health, and medicine working together. So in a nutshell, we had a really ripe and fertile ground. So when Dan and Ray reached out about this opportunity, I was delighted. And Nemi Rajagopal, who's also on our team, she has actually been a core faculty also in the PCM Scholars Program and a lead for the homelessness concentration for the service learning programs. All of us were super happy. Now the question was, how do we implement this? So the way we have decided to tackle this is that we opened up the opportunity to our current PCM scholars, so the incoming class of M1 students. We introduced to them that, hey, here's a neat opportunity. If you want to take this ECMH opportunity, and we've explained to them that this is a pilot and we are integrating this with collaboration with our PCM Scholars Program. And I have to clarify that a lot of students choose the PCM Scholars Program because of its unique, unique teaching and learning opportunities. So they were a little skeptical about, so we won't be able to participate in the health disparity seminars or the community-based work, or how will we participate in our lunch and learn. So we've made all of those opportunities open to them. So we've taken 4 M1 students based on their interests, and about 3 or 4 M2s, about the same number of M3s, and 2 M4s. So these students are going to be our pilot ECMH group, and they're going to work with Dr. Rajagopal at Mile Square. And so we're starting with 1 clinic. And these students will still participate in all the other PCM Scholars opportunities, which include our interprofessional seminars, as well as the end of the year service learning showcase. So we're trying to do a hybrid this year, and really looking forward to learning this year. And I'll wrap this up by saying that, we have been trying to create an opportunity for students to foster the development of critically reflective future health professionals. And this is very innovative work in our research and in our, review of the evidence across the country. Very few people are doing this work, and we are all learning from each other. So we are very happy and excited about this partnership.
Okay, great. I will pass it off to Angela, and I'll advance the slide for you. Go ahead, Angela.
Thank you. Can everybody hear me?
Yes.
Okay. So hello, I'm Angela Blood. I'm speaking from Rush University in Chicago, and my partner is Susan Glick, also from Rush University. Our take on this is going to be a little different because we're newer to the model and newer to this piece of the curriculum. So we're looking at it based on what are the essential components of the education-centered medical home and what's feasible for a brand new start and for our specific context. I will say that's one great thing about being in Chicago is having all of these collaborators at our fingertips. It's been really great to be able to meet with people in person. So some of the things that I think are going for us are having this new program where we are wanting these really robust early clinical experiences and having Dr. Glick, a newly recruited faculty member, to lead it and bring fresh eyes to it. Hopefully something that could at least be begun in our pre-clerkship curriculum and then hopefully carried beyond. We have a lot of people who have that interest in the program, and it's just a matter of figuring out what's feasible and how to make them a key partner in that piece of the curriculum. One thing that might diverge a little bit from the previous presentations is that in order to hit that volume, we're going to be looking at primary care and other specialties and subspecialties to have sort of a potpourri of choices for students. And then the other context is just that we've launched this new pre-clerkship curriculum this fall. So it's really an opportunity to start over, think really broadly about what it could be, and knowing that since the current curriculum is really emphasizing integrated active learning, the best approach would be something like the Education Medical Center Home that brings together all those pieces. So just a little context. Sorry, the color looks a little off. I hope you can see some of that, but just giving you an idea of what the new curriculum entails. So from a macro level, we chose to communicate to students that the curriculum is meant to cover these roles. These are inspired by the Royal College of Physicians and Surgeons of Canada, CanMed's roles. So we're hoping that the purpose of the curriculum is to show students components of content from a lens, like the advocate lens, but also the Education Center Medical Home can help them put these kinds of roles into practice, make the curriculum really real for them. And then what is that secret sauce, as Dr. Evans mentioned and Dr. Curry, and what is the secret sauce that we can put in place at Rush? So these are the things that really stood out for us. So having that legitimate role for students, giving them things that they're able to do, that they're trained to do, that have meaning and value to the colleagues that they'll be working with. Something, like I mentioned, that will bring together the other aspects of the curriculum and make it real and put it in practice for them. And then having that peer learning component that Dan was talking about, having the junior and senior students being able to talk to each other, being able to collaborate, having sounding boards for ideas or questions that you have is something else we're trying to have in the rest of our curriculum. So it would be great if these early clinical experiences could reinforce that.
And so what we decided to do to be able to roll this out, and I'm sorry, Lauren, I may have you advance to that next slide for me if you would.
Sure.
Thank you. So what we decided we really wanted to do is just focus on these three things, the legitimate peripheral participation, value-added education, and peer learning, and build out for at least this year and potentially next year as well, a program that really robustly focused on these concepts, thinking that if we could get these down, we could use that as the core from which we could build a true education-centered medical home. And so what we've done is to build clinical experiences in primary care and specialty care environments. We have consistent clinical teams for the students to work with, including the attending physician, the nurses, medical assistants, and a consistent peer group for the students as well. So examples of some of the things that our students are doing are screening for social determinants of health in primary care settings across our enterprise. Some of our clinician educator investigators have built a tool for the students to use to be able to do this, and the students are really loving that so far, really being a part of things. A program that will be launching in January with the next semester is a program to support veterans and their families through our Road Home program.
in which students will essentially adopt a veteran and help them to navigate some of the stickier places in their healthcare and in navigating the healthcare system. And to, in the orthopedic setting, which you might say seems really antithetical to an education-centered medical home, but at its core offers many of the same sort of teaching concepts and values for the students. This is Matt Coleman, one of our orthopedists, and his focus is on the care of patients with malignancy affecting the spine. And one of the things that he wanted to do with and for students is to have them participate from stem to stern in the care of patients with malignancy affecting the spine. So for the students to be a part of that initial visit and then to participate in their tumor board, to go into the OR and see the surgery, and then to participate in the follow-up care. Working as a team with peers has been a huge emphasis of ours, and the idea is that core group enhances patient care together, has each other to serve as sounding boards if they have any questions, and so they're caring for patients while learning from the patients, while learning from their care teams, and especially learning from each other.
Well, thank you so much to our presenters, and at this time we're going to open up for questions. Again, you can either type your question in the chat box, and I see that we have one already, or you can click to raise your hand to access the microphone. Why don't we start with Heather?
Yeah.
So the first question is from Heather. She's asking, please say a little more about how you're defining what each student does or needs to learn, as well as how they're supervised or precepted. So I'll open it up to our presenters to respond to that question.
I'll jump in first. We at Northwestern, we don't really have any outside of medical trainees right now officially incorporated in our medical homes, but as far as hours of the students evaluated and supervised, within each encounter, every M1 and M2 is supervised the entire time, taking their history by an M3 or an M4 in the room with them, which has been kind of probably the #1 most important thing that we've learned that was the most successful thing we did. So they're getting direct observation every week by peers who give better feedback than the preceptors would. And we've already kind of analyzed this and found it to be true. They are so close to the learning topics that they really do a better job than the preceptors for giving immediate feedback on history taking and initial physical exams. For the third and the fourth years, kind of feedback on their management plans, that's traditional preceptor model. We evaluate them mid-year and end of the year. Preceptors do, that's part of their primary care rotation grade. Works pretty well. I don't know if Ray or anybody else wants to comment on outside of medicine trainees.
Yeah, this is Ramona. I'm happy to comment. We have interprofessional students in 2 different layers. So for the PCM Scholars Program, the 4th year component has students from different disciplines. And the focus of the 4th year component is for the students to learn about community-based participatory research and quality improvement methods. So they work with our community partners to identify and develop a project that they complete over time. So the faculty in the program are also from all the different disciplines, and we all work with them throughout, from orientation to monthly seminars, and we go with them to the community sites to develop the research. And so each of the disciplines have their representative faculty, and we oversee their projects. So the second piece that I wanted to mention was that we recently got a HRSA grant to develop a geriatrics workforce enhancement program at UIC. And part of that program is includes a summer 8-week course for interprofessional students. And again, we had 5 different professions working together, which included social work, medicine, pharmacy, public health, and medicine. And again, we had faculty from all the different disciplines, so we worked with them throughout the 8 weeks, and it included clinical work, it included going to community agencies, it also included work on a project over the 8 weeks, and again, the supervision and preceptorship was provided by the faculty from different disciplines. Hope that's helpful. It's in a nutshell.
Yeah, this is Ray. Within the ECMH pilot itself, I hope I didn't give the impression that we already had the IPE component in place. We do have, I think it'll be a fairly short hop, skip, and jump over to doing that as we get our feet on the ground, starting with pharmacy students, which I know are active at Miles Square. And Nimi, I don't know if any other folks are easily, are likely to be incorporated soon.
So right now, this is Nimi Rajagopal. So right now for ECMH at Miles Square, we definitely have both pharmacy students and residents that are here. We are in the process of transitioning and getting some new LCSWs on board for behavioral health, and they do bring students as well. So in the future, as we get the new LCSWs on board and bring in their students, hopefully we can fold them into the program. The way it does work now for us with students is the PharmD, her student or resident are here and available. She is also a certified diabetes educator, so say we see a patient that has diabetes, she will actually meet with the patient in real time, and so the students that are paired with that patient here would also be able to go in there so that together they would see how the patient is being educated from the PharmD's perspective. And then she does not just diabetes, but blood pressure, asthma, everything. And so we're hoping to fold that in as we go along and start. In terms of how they're precepted, I think as Dan mentioned, we're planning the same model here at Miles Square where our M3, M4s are going to be paired with either an M1 or M2, and they're going to go in together. And then right now I'm the only faculty, but I'll be here, and then we'll all go back in and see the patient together and form the plan together in terms of precepting.
Great. Thanks, Nimi. I'm going to take the second and the last question, and then I'm going to hand it off to my Rush colleagues to take the third question. The second question is how do we pick patients for the ECMH? Basically, within my experience, Thursday is my ECMH day. My schedule's open like it would be any other day. I have 3 sort of hidden spots, patient scheduled spots that the general phone room does not have access to, that only my students can kind of put their continuity patients into. So there's a little bit of a protected bandwidth to get our ECMH patients back in for follow-ups. But if a random patient that didn't sign up for ECMH shows up on a Thursday and they happen to work with my students and they happen to have diabetes and their A1C happens to be lousy, then we basically, before they leave that day, we say, hey, would you mind if my student follows up with you next week by phone? Would you mind if they confirm that you're taking your medicines as we've discussed? And would you mind if they, over time, kind of gradually work with you to get things better? That's how we sort of get patients bought into the program, and I'd say the answer is almost uniformly yes. I can remember on one hand the number of patients that were not interested in that, as long as we approach it in a professional manner and the student looks enthusiastic. Which patients do we recruit? Basically any patient that's going to come back for follow-up visits. So I don't care what the medical condition is, but I do want continuity. If the patient's healthy and they're only going to come in once a year, they're probably not going to see the student very much, and it's not kind of hitting all of our checklist items. But if they have diabetes or blood pressure or cancer or you name it, if they're going to need to come in 2 or 3 times a year, then that's probably enough coaching for the students to really get something out of it.
So I'll jump on to question 3 about the meaning of legitimate peripheral participation. And when I sort of think about having students in the office with me, and I'm in primary care, I'm a general internist, a third-year student can easily participate in the work I do by talking with patients, examining them, helping me to come up with a differential diagnosis and management plan. But for entering first-year students, they don't have that skill set yet. So figuring out what students can do, that they can roll up their sleeves, get their hands wet and dirty, and contribute to the care of the patients we serve, their communities, the hospital in general. The activities that they can do are sort of what's thought about as legitimate peripheral participation. So that can be anything from procedure-related things, learning how to take blood, for example, or put in IVs. It can be looking at records from a population management standpoint of patients who are overdue for screening activities and calling them on the telephone. Or it can actually be in the office seeing patients and doing that component of the history or physical or data collection in general that they're trained to do.
Okay, great. And looks like another question was, are any residents involved in the ECMH?
So at Northwestern, we've dabbled with this. We've only had residents involved who were Northwestern students and graduated and stayed on in the residency program, so they sort of knew what the ECMH was and sort of were not overwhelmed by kind of the chaos of what we're trying to do. Within that kind of small group of residents, it's been great. So we have, I have one resident with their resident clinic kind of under my umbrella on Thursday afternoons. I think I've got 7 patients sort of on my schedule and 5 patients on the resident schedule. So we've got 12 bodies coming in every Thursday afternoon. And I'd say about half of the residents' patients that she sees have really good education kind of issues going on, and she works with my students just like I do and does a lot of education just like I would be doing. But I think it has to be a resident that's sort of open to not only doing the patient care, but doing the education as part of their clinic. I don't know if every medicine resident would be automatically as an intern kind of willing and eager to do that. So I think it has to be a volunteer case-by-case thing.
And it looks like our last question is, how did you get buy-in from your health systems to incorporate students towards improving high utilizer outcomes?
Ray, do you want to take this one?
Well, I don't know if, maybe Nimi can best answer the question for herself since she's the clinical practice director. Nimi, and then perhaps you. I mean, you've been through this in a multi-year way, and I think have accomplished the buy-in very successfully. We're just starting.
Yeah, and this is undoubtedly one of the things that has been a challenge because people haven't seen it in effect. And I think from talking to Dan, we think that once it's in effect and people get a good picture of how it's working and how much it's helping patients as well as the students, that we'll have additional buy-in from faculty. I have no doubt. I've talked to faculty, and faculty are interested. Of course, getting the buy-in from the overall clinic directors and department heads is where our next challenge, and that's our next step, is how we're going to expand this. So I have tons of faculty that are interested. I have additional students that have expressed interest as well. So I think that as we move forward, we're not going to have a problem implementing. It's just a problem with showing what the results are. And I think that that's where Dan can probably speak to how you were able to expand your pool of faculty as they saw the benefits of the program.
I think the number one thing we did was just start small and recruit really good preceptors that we knew were going to have great interactions with the students, and I think it's sort of infectious. If you have 3 really good preceptors and you've got 16 students working with each of them, and at the end of the year all 50 of those people say this was a great experience, and the clinics kind of said, hey, our preceptors are happy and they're seeing patients and they're not losing money, and nothing terrible happened, then it becomes a virtuous cycle of all those students talk to their friends and talk to their peers, and the preceptors talk to their other colleagues, and that's kind of how we grew. We started small, we were successful the first couple of years, and then it took off from there. I think you just have to get a small foothold, prove that the model kind of is not breaking anything, prove that the preceptors are, enthusiastic and engaged, and then I think it just takes off from there.
You hinted at something there, Dan, that maybe you should be a little more explicit about. We did you did monitor pretty closely the clinical revenues that, they hit the clinical revenues there in the first few years and found that it was nowhere near the sort of traditional anecdotal student slows you down by a third sort of situation, that you really had minimal reduction in clinical RVUs overall, because these are complex patients and you were seeing almost as many of them.
Yeah, we saw about 20% fewer bodies, but the bodies we saw were all E4s and some E5s as far as kind of RVU billing. So it was capturing a little bit fewer numbers, but basically at the end of the day, the RVUs were almost a wash. So really the extra above and beyond kind of effort for the preceptor wasn't so much making up a lot of RVUs. It was really just doing the teaching and doing the mentoring. Which is definitely additional work, but I think it's work that's what they want to be doing. They love doing the teaching, and it gives them some protected time to do it.
Okay, great. If there are any other questions, please feel free to type those now. In the meantime, let me direct you to the bottom right-hand corner of your screen. You'll see a few files that are available for you to download. We have a couple articles that were published about ECMH, and then also references that were used in the development of ECMH. And then this is the first of 4 webinars that we'll be doing throughout the year, all related to social determinants of health. So please fill out our evaluation form and let us know if there are any other topics you want to hear about or how we did today. So if there are no other questions, huge thank you to our presenters, and thank you all for participating with us today. And so we'll go ahead and sign off now. Thank you all.
Thank you very much. Thank you.
Thank you.